COVID has affected us all, and with all the negativity surrounding it, it's often hard to find the positive. One of the blessings it has given us is the opportunity to build an avenue for creating change, starting right here in our community, discussing topics that affect us most, such as racism in healthcare, maintaining a positive mindset, creating change, the importance of advocacy, and the many lessons we have all learned from COVID. If you or your organization are interested in speaking engagements, send a message to quadcast99@gmail.com, reach out on Facebook at Quadcast, or online at drkwadwo.ca.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved.
Quadcast Nation, I am hyped. I am excited. I'm standing up and I'm pacing because I'm talking to my boy, Dr. Dennis Kim, who I haven't. When was the last time we see each other?
Honestly, brother, I think it was San Antonio, SCCM, whether that was 3, 4, 5 years ago. I cannot remember, man.
I can't remember. What I remember about that is I took our trainees out for a dinner that night. And I went to one of those like all you could eat all you could eat meat restaurants. 2 out of the 3 were vegetarian. I'm like, why are you eating? And I'm like, oh shit. Anyways, and by the way, people, I like to call Dennis Slash because this man, he has all the assets: intensivist, general surgeon, trauma surgeon. You know what I mean? Intensivist. Like, there's nothing this man can't do. And mad researcher. We got to collaborate like, I think once or twice.
Yeah. We've actually had a couple systematic reviews and meta-analyses that have come out of the resource, I should say, optimization network. Yeah.
Bam. Nice plug, buddy. I love it. And I can't forget, we'll talk about this at some point, but podcaster Trauma ICU Rounds making its way up the charts.
Yeah.
You know what I'm saying?
Yeah.
It's exciting times. So, maybe let's just jump into like, it's the theme of the days. I think we just have to get into it. COVID. You know what I mean? Like you and I have lived very different COVID existence. Do you know what I'm saying? So just, what has it been like being in the, I'm going to call it the jungle, my friend, like where you were at in terms of what you saw and how you guys are doing now?
Yeah, it was, it got pretty scary there for a while. I think we had a couple of surges, and it was the most recent one at the start of this year and the end of 2020, where we really got hit hard on the West Coast and in Los Angeles County specifically. It was amazing just 6 or 7 months what was going on in New York City and the East Coast, and us thinking, it must be the subways and everyone's packed into these tin cans, whereas we're kind of spread out in LA. We'll probably won't have to worry about that. And lo and behold, it came hard. And there was a point I still remember very clearly where there was a resident in Los Angeles County that was dying every 8 hours from COVID. And we just got so overwhelmed. And I got to give a huge shout out to all of our healthcare professionals, especially our nurses. And, I'm a trauma intensivist. And so we're a busy level 1 trauma center down here in South Los Angeles. We see over 5,000 patients every year. And so we were kind of sticking to what we knew in our game because we couldn't close the trauma center doors. And so our palm crit care, anesthesia crit care, healthcare providers, physicians, fellows, residents, they've been working since the beginning of this pandemic. And when that last surge hit us, they were already so exhausted. And it's only then that we actually kind of jumped into the mix or the fold, because at that point, it was all hands on deck. We were so overwhelmed. We had just regular ward beds that were housing 4 vented patients.
Wow.
Yeah, it was amazing. We had the news stations here pretty regularly, kind of just documenting just how severe and strained the system was. There was a point where our morgue was completely filled. And so we had these huge tractor trailers, and they were just essentially these portable morgues or ice boxes. And that's where we were putting our patients. And, we actually wrote a paper on RRTs together, but there was an RRT going on every hour of the day.
Rapid response.
Rapid response calls. Every hour of the day or more when it was really bad. And it was on all floors of the hospital, in the ICUs, in the ERs. We got a brand new, gorgeous surgery emergency building here at Harbor UCLA just within the last 6 years. And our capacity in that ER is about 90 to 100 patients. And we've got a huge acute care side there. Every single one of those rooms was filled with a severe COVID ARDS patient, most of whom were intubated, ventilated, being proned. And it was quite a sight. Sight.
That is unbelievable. Like, I don't know if we fully appreciated it up here, like what was going on in California. Like, we were catching wind that, the volume was high, but that level of death, that level of that description of like the morgues being full, and it might be my ignorance just being caught up in what was going on here, but wow, like I don't think I fully appreciated that. And like, was the experience similar to us? Like the type of patients that you were seeing coming in, like what was the demographic or the socioeconomic situation?
That's a great question, Quad. And, it's not surprising when we talk about social determinants of health and disparities across the system that the vast majority of our patients were Latinx and Hispanic, followed by Black, African American, Asians, and then whites or Caucasians, in that order. And we found the same when it came to mortality and death as well. So by far, it was, our Black and Hispanic community that was disproportionately affected and also sustained the highest mortality. And we're talking young people. These aren't all the old comorbid with, immunosuppression on board. These are young, healthy, or presumably healthy. Again, many of our patients don't actually have access to healthcare, but previously undiagnosed comorbidities. And there did seem to be a certain increased incidence of patients with either undiagnosed hyperglycemia or diabetes, as well as morbid obesity as well. But we just had, when it came to the number of patients that came from the same household, that was also very impressive. And here we have a lot of multi-generational families all living in tight quarters spread out across the county. And so it was just the perfect setup when you have these stay-at-home orders to have multiple generations of these families being afflicted.
So this sounds quite similar to us, like where socioeconomics mattered, like when we have these lockdowns, these, that would be my next question, if there were ties to essential workers. But like, we did see the demographics, no matter what the age, that association with diabetes or pre-diabetes, obesity. But yeah, like not being in positions that they could isolate from their families, multi-generational homes is like, it's so tragic. Like we would legit, I remember seeing families like you would have a family member in the ICU, someone not in the ICU, maybe both in the ICU. Like it was crazy.
Yeah. And, many of them didn't make it. And so you have the patriarch who dies one week, and the weekend following, one of the 3 kids is now dead. And so it decimated families. I
don't know if you found this, Dennis, but it didn't occur to me till maybe a couple of weeks ago. I heard a couple of nurses and staff mention like what the challenging part with a lot of our patients was that you got to know them actually. Like, because they were pre-intubation, they would, they might be on, high flow oxygen. So a lot of oxygen, you could still interact with them. They usually, not demented or have like cognitive impairments, unlike many of our other patients that are coming in with respiratory failure. Like we meet them for the first time intubated often. And so you actually develop a relationship with some of your patients, and then 3 weeks later or a month later, they pass. That was an underappreciated, difficult scenario with this.
Yeah, no. I talk with our nurses in the units and the ERs and on the wards, and I think that sort of moral sort of injury that many of us sustained during COVID, the effects of that we're still feeling. And you're right, it's not like that patient who comes in with like an H1N1, pregnant, florid ARDS, can't talk to you. They're so cyanotic and hypoxemic, they get snorkeled, and then they're in the ICU with their single organ dysfunction. These are patients who are coming in, they're hypoxemic, but they're still able to talk, and they're maintaining their SATs with some high flow and self-proning. And it was amazing how we went from immediate intubation, secure the airway, protected intubation, prevent the aerosolization, and just put them on the ventilator. And all these patients ended up dying to, oh no, we gotta try to put that off. And then let them develop their, self-induced lung injury. So we kept them non-intubated for days and days and days, week, 2 weeks, and they're just swinging these pleural pressures and just causing harm. And then they got intubated. And by then it's like, we didn't really have many options at that point. So it's interesting how this pendulum has just gone back and forth. And we've learned so much as we've come along.
I know this is like our audience, like not or like healthcare providers, not all medical, but I got to ask you about this. Do you think we've been waiting too long to intubate? Like I do worry about that. They're on all this oxygen. You're not regulating their tidal volume. So basically, right. If you take big enough breaths, sometimes we worry that could injure your lungs by taking too big of breaths. And one of the ways that we protect the lungs when someone is intubated is just minimize the volume that goes in and out of the lungs. So yeah, I would love to hear your perspective on timing of intubation with COVID patients.
Yeah, I mean, it's a great question. I don't know that anyone really has an exact scientific answer to that. I can just say is that our practice evolved. We really did kind of come back to more of a middle ground. Mm-hmm. Because there were a significant number of patients who, in retrospect, and again, 2020, you got the retroscope, we probably left, not intubated for fear that once they got on the ventilator, it was sort of like this, we committed them to death.
Yeah.
And the problem, like you mentioned, is whether you're receiving positive pressure ventilation from a ventilator or you're just spontaneously normal breathing like we normally do, if you're having big swings in the pressures within your chest and the lungs, and like you said, you're taking in big, gasping, big volumes, that's lung injury. And so whether it's coming from a machine or you're doing it yourself, I think, it's really important to pay attention to how patients are responding. And there were a couple of small little studies, prospective observational studies, where they would have patients do simple maneuvers like self-prone. So essentially, instead of lying on your back, we will put them on high flow oxygen and then have them lie on their abdomens. And the whole idea is that you improve blood flow, improve oxygenation to areas of the lung that are sick, just by using gravity to your advantage. And some of these studies show that, people who could actually tolerate that for more than a couple of hours actually did pretty well. And patients who didn't tolerate that, many of them ended up being intubated or going on to a ventilator within a few days. And so there were a number of different measurements we would look at. There's nothing more important than looking at your patient, but that was one of the things that we started to work into sort of our algorithm to figure out, should we be putting this patient on a ventilator sooner than later? Only once we realized that we weren't short of oxygen, which there was a threat of that for a long time.
Oh my God, can you imagine?
Yeah, and once we realized like what's going on in India right now, and once we realized that, we do have enough mechanical ventilators at the present time. But I think back to what was going on in New York, and there was a point where there was a complete lack in the whole national cachet of ventilators. Mm-hmm. And so, I think one of the other points that you brought up when it came to moral injury with our healthcare professionals and our colleagues, we were able to develop these relationships with these patients who didn't require intubation and a ventilator. The really crappy thing was that there was no ability to have family or loved ones visit.
Oh my God.
You got to know the patient, but they were never able to really communicate with their family members. I mean, yeah, we had the whole iPad thing and the iPhone thing, but there's a difference, when you have someone who you love, who's sick, and you're at their bedside holding their hand versus doing it over a telephone. That part was it was so hard. Like watching, you'd see people say goodbye essentially in that first wave over the phone or over an iPad. Like legit sit with that people, like the people that you've loved, and you're alone. You're with, all these strangers wearing all this personal protective equipment. It's very dehumanizing, and you're dying and you can't be with your loved ones. Like this is the kind of things that we were witnessing and that our patients were going through and their families were going through. So there was a lot of moral injury. And I'm personally worried, in terms of even when we get through this, how many people are going to leave critical care, healthcare, maybe even in general, like bedside healthcare, because of what they saw. Yeah, I mean that, and then you combine it with the fact that we have here at least we have a national shortage of nurses, and so just trying to get by, and you have nurses who in the ICUs are already managing 2 patients at a time, and now you hand them 4 patients at a time, and then maybe throw in an NA or someone else who doesn't have a nursing background into the mix, and we have these team-based models that, organizations like SCCM and others promulgated, but they look way better on paper than they actually worked out in terms of the real world.
Yeah. I mean, one thing I would say though, Dennis, that I hope we get to retain, I think you'll agree with me on this, within not just critical care, but in medicine, we're very resistant to change. We I don't know at your site, but even doing a spontaneous breathing trial, sometimes you got to twist somebody's arm, basically a measure to see if someone's ready to come off a ventilator. But, the agility, like what you were describing about us being able to shift gears and to adapt to evolving data. I have never seen this in medicine, man. Like I'm telling you, things that we know are 10 years, 12 years old that are evidence-based practices still don't get widely adopted. I hope we hang on to that part of the pandemic was beautiful.
Yeah, no, I mean, I can't believe we're living through a pandemic. Like who would have ever thought, like when we first went into critical care quad and we were learning about ventilators, we talk about the polio epidemic, the polio epidemic, Denmark, 1950s, medical students giving mouth to mouth, for their entire shift in order to keep these patients alive, and these negative pressure iron lungs that people were put into.
Yep.
Never mind all that, man. We just lived through COVID-19. We're going through COVID-19, and I totally agree. I mean, I think some of the medical advances that we've made, whether we're talking vaccinations or, understanding the role of medications like dexamethasone, and just getting those trials pushed through so quickly. And I mean, what was true yesterday is false today and vice versa. So there's just been a huge just outpouring of information that has relevance at the bedside in the care of our patients. It's really incredible.
It's been great. I mean, you brought up vaccinations too, and for some reason I was a bit reluctant to use the term miracles, that these were the vaccines were like essentially miracles. But I actually think it's appropriate to say that if you think about how quickly they developed and how safe they've been, and all part of the amazing medical developments over the course of this pandemic. But I think you and I have had different experiences when it comes to rollout, my friend.
Oh, like, my goodness. Yeah. Dude, what is going on up there? I had to, before we got on the call, I had to check out like what is going on with the rollout up there. Cause my folks are still, knock on wood, healthy. They're in their 70s in Toronto. My brother's a teacher up there. And, he just got his first shot like 2 weeks ago. And there's no plan to get a second shot. And I know the same is happening for healthcare workers in Toronto, and I'm sure in Ontario as well as BC. My wife and kids have been up on Vancouver Island since November. As soon as things got really bad here and we had to do Zoom school for 4 different kids, hours of the days, and we knew that things were still open on the West Coast in Canada, they headed up there to be with family. And even there in BC, you can't get a vaccine. I mean, sure, if you're vulnerable, elderly, but for the regular run-of-the-mill person, you just can't. And here, I can just go to my local Pavilions or Vaughn's supermarket, and they have free vaccines. Just, walk into the pharmacy and they'll give you a vaccine. And I look at our numbers and, we're at about 40% of our population vaccinated. And so in California, we're doing a great job. There's been a great push. I personally got both of my shots, I think back in February, January. And I just remember it being just so, such an emotionally charged experience.
Right.
This feeling of like, just this added sense of security. Yeah, words can't even describe that. But what is going on with you guys? I think you guys are like at 4 or 5% of the population with one shot in their arm.
No. We've ramped up big time.
Oh yeah, is that right?
Now we're approaching 50%, if not. What? This is for first dose. Yeah, so this is May 19th. Timestamp this bad boy. We've really wrapped it up, and so. I think I can't remember the date where 18 and above are eligible to get mRNA vaccinations. We've shut the door on the AstraZeneca side of things, man. But that communication piece, we've bungled the communication piece big time. But yeah, the vaccines are finally starting to come out, and I think. If I'm not mistaken, you guys have been seeing the dividends. If I'm not, like in terms of hospitalizations and even case numbers in Cali, am I wrong?
It's been a complete 180. I walk through the hospital now, and we have maybe a handful of patients with severe ARDS or COVID-19. And yeah, it's just it's night and day compared to where we were just a few months ago. And I think in LA County specifically, they've done a fantastic rollout, really making the most out of public forums, arenas, and just making it easy for people to get that shot. And so they've done a great job, and I'm really proud of them.
I like that idea, though, making it easy. I think we were a little bit late in the game, if I'm being honest with you, like online portals. And you think about some of the hardest hit spots, like, your brothers in T-Dot. So you're in Peel, Brampton, not everyone has easy access to the internet and what have you. And so we were a bit late to the game to approach the hotspots, like have that approach where we bring the vaccines to where the problem is. But now we're finally starting to see the light at the end of the tunnel, because, our kids right now ain't in school. We have a stay-at-home order till June 2nd. But so yeah, we had some work to do, but we're starting to see the light.
No, that's great. And things have opened up quite a bit. I get a little concerned, when you hear these messages from the CDC about, if you're vaccinated, you're indoors, don't worry about the mask. And if you're outdoors, don't worry about the mask. There are still variants out there. Not everyone has their second shot. It's not 100%. And we're still in the middle of a pandemic. So some of these messages, I got to say, I am a bit concerned about. And I worry that if we hasten reopening too quickly, we're going to be back into another surge.
Yeah, I hear you about the concern. But you guys also have like some crazy, not in Cali, but like whatever's going on in Florida and Texas. Like they went the extreme route.
Yeah.
And so far, at least I haven't heard of there being surges, but I a mix of vaccinating, a mix of natural immunity, a mix of, the time of year you would think, but holy cow. I mean, it's
very diverse and differing approach depending on what state you're in. And I just happen to be in a blue state, California, which I always thought if any state should be sort of incorporated into Canada. I think we take all the states along that west coast there,
Oregon too.
Oh yeah. Well, maybe some parts.
I love Oregon. I'll stick with Oregon State. Washington's a no-brainer, man. If you live anytime in Vancouver. But what were your thoughts? Like, COVID in general put a real lens on where our deficits in the healthcare system were. It also put a lens on race and outcomes. And did that impact you, or even the whole race angle? Like there was a lot of overt racism, even in terms in the Asian community when it came to COVID, like, and this is also we're approaching a year, George Floyd. So even the racism in general has had a lot of traction. Have you had any recent experiences in terms of, being of Asian descent and during this time that you could speak of?
Yeah, I mean, personally, I think I'll use the word privilege because I am privileged and I acknowledge that, and fortunate and lucky that I personally have not experienced it. But you just need to turn on the TV to any news station and you'll see overt acts of hatred and racism and discrimination. And yeah, it was really interesting to see and saddening to see it affect obviously the Black community, but also the Asian American Pacific or, Islanders as well, and people of Asian descent. And I know that was also happening in Canada, but it was happening so frequently here that, just yesterday I saw that they were passing a bill, that these are hate crimes. And it almost seems like a no-brainer that, obviously, you're like going around and assaulting these like elderly Asian people who are defenseless. And so, it was disheartening to say the least.
Yeah, it is sobering too, man. Like it's just, you just, when it's 2021 or what have you, you think a lot like we'd get past a lot of this. And I must say the racism awareness has been great to see. But it still baffles me to how ingrained, how systemic some of this is. And, I know the States is probably better at this, but even locally, we didn't capture race-based data, till summer 2020, and when you look at the hardest hit spots, the hardest hit communities, it was hard to accept that we wouldn't be having a tighter, bigger lens on race-related issues. But yeah, I could speak personally, like that part of COVID, seeing people that look like you, not only getting more cases, also getting most severely ill, dying, being hardest impacted by the restrictions, joblessness, schools, all this stuff. And it's setting up the people back that were already on the margins. It was just a hard pill to swallow.
Yeah, no, I think one of the things that this most recent pandemic has definitely brought light to is the fact that structural racism, structural violence exists, and it's invisible. It's something that you're not aware of until someone actually points it out. And it's incredible that there are just so many systems in place, whether it's political, economic, financial, that really determine someone's trajectory from birth. And these are factors that we don't have an influence over, or that many of these innocent victims never had a chance to change because they were born into certain conditions that were perpetuated with no way to really get out of those particular situations.
And that's why I think when it comes to this stuff, it really, that level of understanding and having that level of compassion is so important. Like realized because of those structural systemic issues, that battle to get to a seat at the table is extremely difficult. There's that many more hoops to jump through.
Absolutely.
It made me think about too, that it's like you and I, we finished around the same time, and you're experiencing healthcare in the States. Okay. And you always hear, I always get this question. You ever think about heading to the States? Would you ever consider, I don't know why I'm using that voice, but like, yeah, would you consider working in the States at any point? And my personal belief was always no, but you're there, you're living it. And so I'm curious, I don't know if we've really jumped into it even offline, as like what it's been like in terms of even at a system level, on a patient to patient level, like what has it been like being south of the border?
That's a great question, Quad. And honestly, I have a little bit of different lens when it comes to that particular question. And that's mainly because as a Canadian, I'm used to a public healthcare system. And in many parts of the US and in many different healthcare systems, obviously it's two-tiered. You've got the private side of things. I've been blessed that because I'm a trauma surgeon and I mainly treat and care for patients who are uninsured, marginalized, and an indigent patient population, that I've always worked in a county hospital setting, which is essentially public healthcare or public access. And so, currently I'm down in South Los Angeles at Harbor UCLA Medical Center. In addition to being a level 1 trauma center, we're essentially here for any and everyone, irregardless of ability to pay. So the vast majority of our patients, many of them will have Medi-Cal and Medicare, but many of them come in without private insurance. And so I've never had to really bill. This sounds a little insane, but I've never had to generate RVUs in order to be financially compensated. I see a patient, I sign the consult note, and that's pretty much about it. I don't have to keep track of procedures that I'm doing in order to get remunerated. And as a county physician, I'm essentially on the clock. At minimum, I do 40 hours a week. For most of us in our trauma group, we do about 100 to 120 hours a week. And that's how we get compensated. So it's a little frightening because as I think about, potentially after 10 years of being here, moving on to my next adventure or endeavor, I feel a little ignorant because I really haven't been exposed to all the bean counters that are sort of, really kind of keeping track and tabs on your productivity as well as your margins.
Wow. So I guess this is a bit of a different answer than I was expecting. Like, I talked to a trauma surgeon, Dr. Nee Darko, and he was describing a bit of, the insurance issue. And so it's kind of nice to hear that you haven't had to deal with it. That would trouble me to a great extent to have to think about, compromising care based on what insurance policy somebody has. And so I'm reassured that you didn't have to deal with that. But what about you hear a lot about it being a litigious environment down south and did you experience any differences in practice based on these concerns?
Yeah, no, that's another great question. Again, personally, I think I've been very fortunate in this particular setting, where our patients tend to be financially disadvantaged. When they first come through our doors, whether injured following trauma or because they've got an acute medical illness, this is oftentimes the first time in their adult lives they've actually encountered a physician or the healthcare system. And I think there's just so much gratitude that there are centers like ours where we're open 24/7 to meet any and all medical needs you have. They're just so happy to actually speak with someone and have someone care for them and then provide some continuity or try to get them impaneled into LA County Care, or to, meet with a social worker or case manager so that they can get their mom Medicare or their father Medicare, that they're just so grateful that I don't think they're really here to kind of sue, and be litigious. I think there's a lot of gratitude. And honestly, it's one of the things that really makes working at a county hospital so fulfilling. I mean, most county hospitals are always going to be the hub for academic teaching programs, residencies, and most will also have some sort of level 1 or 2 trauma center. But it's really the patient and the mission that makes it such a satisfying and wonderful job to be in.
No, wow. And that's honestly, I'm glad to hear that, because it sounds like it has been a rewarding experience. I was also thinking too, Dennis, like you going from a Ottawa trauma center to LA County trauma center, you must be seeing completely different like patients coming through the door. Hey,
yeah. I mean, again, I think if you look at the epidemiology of injury throughout the U.S., falls, gravity, motor vehicles are always going to be the number 1 and 2 in terms of the mechanisms of trauma. And then we have, actual gun violence. Amazingly, when you actually look at the incidence of death across those 3, although firearms accounts for maybe in many centers, maybe 4%, 5% of the actual overall trauma, the incidence of death is actually equal to those other 2 mechanisms. And so it's amazing. I think back to Ottawa, I spent 7 years there. I saw 1 gunshot wound. That was
one people, one
non-operatively, which is, it's amazing. I mean, you got to love Canada, right? Like restrictive gun laws and access to guns. And we saw 1. And actually, that was one of the major drivers of me coming down to the US and to California, San Diego, and then LA County for the last 10 years, was I never really got a lot of experience performing operative trauma, because so much trauma, as in the ICU, is non-operative, right? You bring them in, you manage their ICPs, transfuse them some blood, get them for an angioembolization if their spleen's bleeding. There's not a lot of operating. And so going down to San Diego was my first real experience with penetrating trauma. But even there, San Diego is a beautiful city and it's fairly safe.
Amazing.
Yeah, amazing, right? Legoland, the zoo, all of it, just amazing. Balboa Park. But once I got to South LA, that's when we really started to experience trauma. And here, definitely since the beginning of the pandemic, we've seen a big uptick in terms of the amount of interpersonal violence, self-harm, as well as gun-related injuries. And during the summer months, usually between June to October, we usually see on the order of at least 2 to 4 gunshot wound victims a day. And It comprises overall, during the peak months, about 30% of all the patients we see will be coming in with a penetrating mechanism, so stab wound, gunshot wound. So yeah, it's really unfortunate to see, but there's certainly a need for trauma surgeons, as well as not just caring for our patients once they've been injured, but also for the primary, secondary, and tertiary prevention as well.
Wow. So like, I'm gonna say that like, that's a different world, man.
Yeah.
That's a different world.
It really
like when
is.
you're going from 1 GSW gunshot wound per year. And
7
honestly,
years.
7 years. Sorry. 7 years. It's funny too. Actually, I'm thinking back at ICU. Maybe I've seen 1 in the last 2 or 3 years. 2 to 4 a day in peak season. Wow. I mean, I just think to myself, the perspective you must have when you come from a country where the gun laws are so much more restrictive. Like, right. Do you have, I don't know, is that a battle for you mentally? Like, when you see that many people, am I lining you up to get in trouble actually with that question?
No. I mean, we're talking about this all the time, because we are really trying to change the narrative as well as the perception of firearm injuries and firearm related deaths. And we're taking more of an epidemiologic injury prevention and almost like a biopsychosocial approach to this, to have people understand that the gun or these firearms are just the vector. There's also a host. There's also population related factors and other things that contribute to these happening. And so where along that sort of chain can we make changes to decrease the burden of firearm related injuries? And it's unfortunate because, again, similar to like we were talking about with COVID, this is a disease that disproportionately affects young Black males, as well as young Hispanic and Latinx males as well. And so plenty of years lost, so many broken families. And, not a 24-hour period goes by at our hospital where we're not seeing someone who's involved in some sort of a shooting. And then you also have the incidence or the issue of recidivism, because many of our recidivism is just, happening again and again. We have patients who, are stuck in this vicious cycle of violence. And again, a lot of this comes down to the oppression and the structural racism that is so prevalent in this country and many countries around the world. And it's this never ending cycle until one day it's that final incident where they just can't survive or don't survive.
You made some reference to making, more some systematic change. Like, are you working in that sense or is this something that you're just like becoming more aware of, or is this something that you're getting involved in, or your department's getting involved in? Because that's what it comes down to. Like, honestly, you and I are very similar at stages in our career, and my epiphany, take a step back. My epiphany came when it came to COVID, when I was, our research is on how to reduce spending, right, and improve care, and then you see these patients come in with COVID, and they have often like modifiable risk factors, like their obesity, their hypertension, their type 2 diabetes. And then I'm saying to myself, man, imagine if we started to intervene earlier to be able to prevent this.
Right.
And the same thing with Mike Hartwick. He's the one that kind of got this in my ear about with us starting Bridges Over Barriers. So like it's a charity that we use to give basic needs to kids in the community, so that ultimately we're thinking that they prevent them from overdosing, from the mental illness side, from suicide and all that stuff, intervening early so that we could prevent them from coming in the ICU. But we're at, unfortunately, mid-career now, you know what I'm saying? This is stuff that we're not talking about in medical school. So yeah, the long-winded question is, are you guys getting involved? What inspired it, and what's it looking like?
Yeah. So again, great question. I'll be honest with you. It's something that I'm just starting to familiarize myself with and sort of immersing myself into. In our group of trauma surgeons and the folks from the emergency department, as well as social work and some of our community partners, we've developed a hospital-based violence intervention program, HBVI. And that's a model that has been incorporated into a number of trauma hospitals and has almost become a mandate to be a trauma program here in the United States. And what these programs do is, at the time of hospital admission, we identify patients who are victims of crime or patients who are involved in gangs, and we reach out to them. And we have partners in the community, many of whom have actually been involved in that gang life and have been sort of reformed, if that's the right word. And they'll help connect our patients and their families with resources, things like tattoo removals for patients who have gang tattoos that are visible, helping them to get graduate education or graduate from high school, as well as finding jobs and employment, as well as helping with medical, legal, and legal fees in cases of a wrongful death. So there are several programs like that out there. with the AAST, American Association for the Surgery of Trauma, I'm one of many members of a prevention committee. And there we're always talking about things that we could be doing, not just in the sort of secondary or tertiary phases. So, primary, we think primary prevention. What can we do to decrease the burden of firearm related injuries? Well, obviously we should be doing background checks on people. If people do have mental health disorders or a risk for depression and suicide, how do we get them plugged in so that they are a decreased risk of harm to themselves or others? And how can we improve our background checks, for example? Secondary prevention. So once someone's been injured, secondary prevention really comes down to is how do we decrease that burden of death? And that's where things like the Stop the Bleed program has come into play. And that's a program, the American College of Surgeons Committee on Trauma, as well as a number of other organizations, which was developed following the Sandy Hook Elementary mass shooting. And the whole idea there is once someone is shot, how can we stop them from dying before they arrive at the trauma center? And so placing tourniquets, wound packing, direct pressure are all things that we're trying to educate our population on broadly. And then the HBVI, that all kind of comes into play as a tertiary prevention. So once our patients survive that injury, how can we get them reintegrated? And oftentimes that also not just involves screening for things like gang involvement, but also screening and treating for PTSD, as well as alcohol screening and brief interventions, which has become a mandatory part of our trauma care from day to day.
I mean, I got to tell you, this is the stuff at this stage of life that gets me really excited. Knowing that there's steps being made to try and, primary prevention for preventing people from walking in the door, but also coming back. You know what I'm saying? Because honestly, there's probably, in my opinion, this is something that I think is just so undervalued right now, is that prevention piece. That, I really think even from a cost-effective point of view or just a moral point of view, really investing in that element, like what we could do to get people to prevent them from walking in the door in the first place is huge. And huge. I would love to see, I'd love to see if there's been much in the way of evaluations of such programs, but, and because I think, when it comes to change, sometimes you do need that formal evaluation. And this is, one of my biases when it comes to decision makers. They love seeing the bottom line. They love seeing how much they'll save or not save. And so that's why we've really put a focus on adding cost to so many of our projects. But yeah, so I guess the question is, do you know if a lot of these interventions have shown to be influential, or is it just kind of at the stage where, a lot of this is being evaluated?
Yeah, I mean, certainly here we're evaluating it in Los Angeles County with the development of our Trauma Recovery Center, but there are plenty of data out there from other more mature systems. And again, this is really a team sport. We're talking social work. In our case, our community partners, Crossroads, nursing, social work, trauma, ER, nursing. It really is a team sport. And so our experience here is still early, but there's plenty of other more mature programs that have shown improvements in terms of our patients and recidivism, as well as reintegration, as well as potentially decreasing costs of readmission and recidivism as well.
I can promise you I'm never going to say that word ever in my life. Recidivism. You got me. Recidivism? Recidivism.
Boom.
Yeah, say that 4 times fast.
Right?
Yo, listen, one of the things we should reflect on too, like I keep saying mid-career. I think that's fair to say. Hey, we're mid-career. Is that what you're saying?
Dude, brother. I mean, we've been out like just about 10 years, right? We finished Crick Care in 08, 09.
I finished in 2010, dog.
10. Okay, yeah. So yeah. Okay, yeah. I did 10 too, because I did another 2 years in San Diego. So 08 for Ottawa, 2010. Dude, it's 11 years. We're career.
So like reflections, like when you look back at where you are now, where we are now, is there anything that, like, are you happy where you are? Are there things that you would change? Would you do this all over again? To the few folks that are listening that are thinking about careers in either critical care, trauma, surgery, and once again, I'm just for the audience, you're also like prolific researcher. I love your research game because we have the similar kind of like approach.
Yeah.
Podcasting, knowledge translator. Like, would you do it all over again?
Yeah. Honestly, I couldn't imagine doing anything differently. I feel that every day I come to work, and this is no joke, and I tell people this all the time. I drop right now, because my family's all up in Canada, we have a dog sitter, Joshua. I drop off my dog there. I start driving in. I listen to my Calm app, Tamara Levitt. And I think
you listen to your what?
My Calm app. Yeah, Calm. Nice. Yeah. Little, self-reflection, meditation, mindfulness on the way to work.
While driving?
Yeah.
Oh man, let me try and tap into that shit. Okay. Player?
And honestly, I think to myself every day I come to work how fortunate and blessed I am and how much I love my job, because I know that I'm going to be helping someone and doing some good. And, to be able to do trauma together with critical care, emergency general surgery, amazingly, it's much easier to do that down here in the US, because just by virtue of being a trauma surgeon and the fact that critical care here is very compartmentalized, it's easy to do all three of those things. I think it's much more difficult in Canada, where, surgeons oftentimes don't have a foothold in the ICU. And so maybe they can do the trauma, maybe they can do the general surgery, but not the ICU. And so, yeah, I think I wouldn't change anything. And there's so many lessons learned. The one thing that's always persisted is I know nothing. And every day there's something new to learn, which I just love. And like you mentioned, the podcast, I think has been wonderful, because you get to just meet, really interesting, cool people, people who are doing the research, people who, you otherwise might not actually get a chance to talk with outside of maybe a meeting. And even then it might be all kind of awkward and weird because they're having drinks with their friends and you're like, hey, you don't know me, really like you, what's up? And it just gets all awkward, right?
Can I be your friend?
Right, exactly. So yeah, that's been a lot of fun. And, being in academics, I think is also, we're very fortunate. The ability to stay on top of cutting edge research and teaching. And so much of teaching is learning. And again, like you mentioned, the clinical research, it's tough to do that whole triple threat thing. And I think these days, most people try to focus in on one or two areas. And that's probably the better way to go these days, because I think there's just too much. And also you got to throw in administration into the clinical, the education, the research. We have a lot of administrative. You have a new administrative role.
Word.
Yeah.
This will be the first show we've done, I think. But yeah.
How about you? You tell me how's it been for you? What's the journey been like? And then tell us about this new leadership opportunity or position.
I feel like I'm on your show. So I'll get it out of the way. Yeah, it's a new department. Well, as of July 1st, I'll be department head for critical care at the Ottawa Hospital. Crazy.
Incredible. Congratulations, brother.
Thanks, buddy. It's I'm still, it still doesn't feel real actually, but yeah, I think our job it's an absolute gift, And I say, like, even if you think about how it's played out throughout the pandemic, like, think about this. A lot of people stuck at home, no interaction, no connection. We got to go to work with a purpose, right? The purpose to get our patients through, get to have that, like, truly meaningful interactions with people. Like, there's nothing like a pandemic to put that into context. You know what I'm saying? Like, how meaningful life is, how important it is to connect. You really get a sense of where your values are, what's important in life. You know, part of the job too that people don't appreciate that you alluded to is, like, you don't know what's coming through the door. You have to be on your toes. You have to be willing to learn. I've learned so much from, I've been in situations where the medical student made a diagnosis totally made us pivot in terms of a patient's management, like having that environment where you like, it truly is a team, and you gotta stay humble. Oh my God. Like if any of the upstarts are listening, you gotta stay humble. You know, the nurse, the freaking PSW can make a call sometimes. You gotta listen, because, oh man, I changed that urine. It smelled funny. That patient's here for COVID and urine smelled funny. But okay, maybe you're onto something. I'll give you a Tober bomb. You know what I'm saying? Like you gotta be like, if you really want to do this job well, you have to be humble, keep an open mind, and that triple threat element. I gotta tell you, that part, I won't lie, has been exhausting. Whether you're trying to be an educator, or a researcher, the podcasting, the admin side, and but one thing I will say has been absolutely rewarding is just like thinking about scale. So this is why I think that I've been so much enjoying the podcast stuff, because like the amount of knowledge you get to throw to the world, it could be logarithmic.
Yeah.
You know what I mean? And so like, this is the part where I get really excited, because some kid, some upstart in Oklahoma could be listening to this bad boy right now and being like, this is why I'm going to approach medicine. Like, you could have that kind of ability to throw down, which has been a huge change from when we were, thinking about, or when we were even finishing our training, because it's been that long.
Yeah, it really has been. I mean, and you look at sort of 2010, that area or that time, that's when sort of like MCRIT, Scott Weingart, and all these other sort of foam ed podcasts started coming out.
Yeah.
And then, in the last 10 years, the podcast industry has really exploded. I mean, I think the latest numbers in iTunes, there's over 1 million podcasts, 1 million.
Yeah.
And I mean, can't imagine how many episodes that are out there to download. And I agree. I think the reach, as well as the ability to kind of interact with your listeners, it's unparalleled. And you can't get that with YouTube or 5-minute little videos. I mean, when you're in someone's ear, whether it's they're on a run or at the gym or shopping, it's not 5 minutes. They're dedicating 20, 30, 40, an hour sometimes. Yeah. And so it really is impactful. And again, I remember just like during fellowship, if we did a teaching activity, it usually meant, like 6 residents in a classroom, and then you pulling up your old ass PowerPoint, the same old slides. And you do that like 6 times a year. So your reach was, 36 students, 36 residents. Man, we throw down a podcast episode and like thousands of people listen to that.
Yeah.
And so, it's been,
it really is
incredible.
crazy.
It really is crazy.
It really is crazy. And it's a great way to amplify. Like I tell the youngins, actually it's part of my platform when I applied for the position, is like, it's not enough now to just do research. Like you got to think about how you're going to amplify your message. You know what I mean? What's going to be the knowledge translation? I think it's important to have a social media presence. You're going to hear this now. Like our department's going to have a social media presence, going to have an updated website.
Nice.
It's going to throw down, because I think this is the future.
Yeah, no. I checked out the website a couple of days ago, and I was like, I think I saw these fellows here like 4 years ago, dude. And like, what is this?
My God.
But you're right,
give us time.
And I know nothing about business and marketing, but I think of what you're talking about, or a lot of what you're getting to, is you got to have a brand these days.
Yes.
You got to have a brand. So as you're starting out, figure out what you want to really focus in on, and then make that part of your brand. So if it's education, figure out in terms of what particular sort of aspect of education and the best way to get your message out there, and build a brand for yourself. And I think it is important to be on social media, to be responsible on social media. Again, having a web presence, and so much also comes down to, again, engaging with others, and believing in yourself, and looking towards making yourself better every day. There's something new to learn.
Absolutely. And, I do want to touch a little bit on research too, because as we mentioned, you and I are both do quite a bit. And I'll never forget as fellows. You know what I'm talking about? I remember doing this presentation on race and palliative care outcomes. And I love Dennis because he just lets you know how it is. He's like, Quad, like, this is one of the worst. Oh my God. This is one of the worst presentations or projects I've ever seen.
Dude, I think my project was penetrating violence in Eastern Ontario over a 5-year period. And the other project I did, and neither of these were published, was like tracheostomies in the ICU, a descriptive experience.
Oh, man.
Yeah, that was bad.
But the point I want to make is, I don't want to take the. I often offend ICU docs researchers when I say this. Is like, if we're honest with each other, we haven't moved the needle in critical care outcomes in how long? Yeah. And so I always like to ask like a fellow researcher, like, what is it? Like, are we not thinking big enough? Are we thinking too small, or do we are we not encouraging enough diversity of perspectives when it comes to our research? But do you have any insights with this shit?
Yeah, I mean, I think depending on the topic, it can be all of the above. Yeah. And so, as a trauma surgeon and as you as an intensivist, you see TBI all the time, right? Traumatic brain injury. Patients coming in, bonking their heads, whether they're on, a blood thinner or not. Nothing has changed when it comes to managing these patients since like the 70s, 80s. I mean, we're in the 21st century and we still can't figure out how to optimize outcomes in patients who have suffered a TBI. Mm-hmm. So again, I think some of it may have to do with the actual disease process or organ under investigation. Mm-hmm. Another factor or something that we should be thinking about is that there's so much interconnectedness between organs in the human body. And a great example is like renal failure or kidney problems. We know that a lot of hospitalized patients, especially those patients that come into the ICU, have, will have an injury to their kidneys. And now we're starting to realize, it's not so much a kidney problem. It's probably more of a heart problem. And the other thing we're starting to realize is that those people who have even just a slight bump in their creatinine, which is a measure of their kidney function, guess what? 6 months, 12 months later, they're at an increased risk for cardiovascular death. So I think, change is slow. I think in certain areas, we have moved the needle a bit. And, I think as our science gets better and as we start to get a little bit more personalized and really start to take advantage. Amen. Yeah.
Oh, man, the personalization, I think this is where we were missing the boat, actually.
Yeah.
You know what I mean? Like if I think
of a large part of it.
Yeah. Like it's just like a random example. You get what is like just the way you frame the question. Like maybe there's a signal towards if you get just a random example. If you get steroids in someone that has a bad infection, septic shock, what maybe we shouldn't be asking if everyone that you evaluate, if you give them steroids, are they going to improve or live or die? But maybe it's what you need, what population seems to be most responsive.
Right.
You know what I mean? And then to the other part of your question or a comment about like, thinking about things more holistically. I think that's part of what we're missing too, is like isolated outcomes that are, isolated interventions that are very specific when we know, right. Your heart matters, your lungs matter, your kidneys matter. So to look at things in a more holistic lens, I think this is another thing that we're missing within ICU research. But I think it's coming though. Like I think there's enough people that are like, especially the personalization side. I think some of the upstarts coming through. It's like we need to, in my opinion, pivot how we've been approaching things over the last how many years and really think about things at a more global lens.
Yeah, no, I mean, like early goal-directed therapy is great. And we learned a lot from that and what works and what doesn't. But the fact of the matter is patients coming in with sepsis have particular pheno and genotypes. And I think we're starting to realize that there are a limited sort of number of different types. And so if we can start to pinpoint, hey, this particular patient is of this phenotype, then maybe we need to target interventions differently for that patient versus another patient. You know, it's amazing. You see some of these patients, they come in and they're just in this hyper inflammatory surge response. And no matter what you do, their body just wreaks havoc against their body. And then other patients, they just kind of come in, you treat them the same way, and then 48 hours later, they're better. I mean, so much of that is going to be related to, I'm sure, underlying environmental, genetic factors are also going to play a role. And then again, the presence or absence of comorbidities that have been till that time perhaps undiagnosed, as well as, of course, timeliness and aggressiveness of interventions.
Yeah, I agree 100%. Listen, Dr. Danny Kim, aka DK, where can people get a hold of you?
Yeah, so you can follow me on social media. I'm at Twitter, Instagram, Facebook. The handle's at Trauma ICU Rounds. That's also the name of the podcast. We're doing pretty well here in the US, but would love to get a little bit more of a foothold in Canada. So if you're interested in trauma, emergency general surgery, critical care made clear, concise, and simple, tune in. We're on iTunes, Spotify, all the major podcast directories, and would love to hear from you. I'm at DennisYoungKim@gmail.com, or just reach out to me at traumaicurounds@gmail.com, my brother.
Oh man, I love the show. I got to tell you though, is when I knew you were doing a podcast, it wasn't what I expected. You were all business. Like I don't know if this is coming through, guys, but like Dennis and I we're a bit cut from the same cloth. We don't take ourselves too seriously. But what you on a podcast is like, ladies and gentlemen, we are going to enter this. It's total serious game, man. It's good though, man. I learned a lot quickly. And I think for all our trainees, especially, not even trainees, but like your early career, they need refreshers on specific content. This podcast is pure gold, yo.
I appreciate that. I appreciate that a lot, Quad.
Absolutely. Well, thanks again for doing this. You are a gem, my friend.
So good to see you. I'm glad we could get together.
For real, you too.
All right, man.
Quadcast Nation, thank you so much for listening. That's my boy, Dennis Kim. I hope you loved it as much as I did. Follow us on Instagram, YouTube, Twitter, Facebook at Quadcast. Leave any comments at quadcast99@gmail.com. Get on the wellness campaign. Get on that solvingwellness.com, solvingwellness.ca. Help us change that boogie in the healthcare space. Reduce that burnout. Leave us a 5-star rating on iTunes. It's much appreciated. It helps with the visibility of the show. And y'all, stay safe, stay beautiful, and we're going to connect again real soon. Peace.